Okay, so good evening to everybody. I hope we are doing very well. Let me share my slide and then we can start the lecture. Let me share my slide and then we can start the lecture. Okay, so we've been on a journey for some time now, trying to walk ourselves through introduction to pathology, the exposure of ourselves to injurious agents, and how the body responds accordingly. And in terms of the body trying to adapt, the body trying to, in the case it's not able to adapt, sustaining some form of injury. And then today we are going to see how the body responds to invasion from some infectious agents, how the body responds to some foreign or even necrotic debris within the body, some foreign bodies or agents that get access to it as a result of inhalation, traumatization, ingestion, or even through other means from person to person. And so we are going to look at how the body responds to all these things I made mention of earlier. So at the end of the lecture, I expect that you'll be able to know the causes of inflammation, understand the process of inflammation, comprehend the etiopathogenesis of granulomatous inflammation, and then be able to contrast the differences between acute inflammation and then chronic inflammation. So I have a very beautiful picture here trying to help us appreciate a break in the continuity of cells. And here it has led to a tissue injury. And we can see some cells trying to leave from the vessel there, the blood vessel. And some of these cells have actually gotten to the point where there is an injury and it is trying to remove the causative agents or other microbes or some foreign bodies that have gotten access to the connective tissue as a result of the break in the intact barrier. And so clearly we can see some trying to engulf, some trying to attach, and all that. Interestingly, the cells are moving out of or coming from the vascularized connective tissue, which is actually the blood vessel. And by this, we are looking at the definition here. We are looking at the definition here, and we have inflammation. And so inflammation is the protective response of vascularized connective tissue to injury, which is characterized by extracellular fluid and leukocyte accumulation that is intended to eliminate the initial cause of injury and to initiate repair. So we see that there is the vascularized connective tissue, and the vascularized connective tissue is the blood vessel to injury. So the response is actually for protection, and we get to know blood vessels are involved. We get to know that there are fluids, which we would later get to know that it is actually called exudates. And then we have our leukocytes that are also involved if we want to eliminate the initial cause of injury. And then when there is elimination, we expect that there will be a decline in the whole reaction. And when there is a decline in the reaction, then the replacement of the lost tissue or cells would occur. And the replacements can happen through repair or through some of the distinct processes by regeneration. Because in terms of regeneration, then we know that the cells involved were actually labile or stable cells, and the stromal framework were not destroyed. But in a situation where the damage affected permanent cells or the basement membranes or the stromal framework were affected, then we know that the replacement of those cells will be by repair. So inflammation is a protective response of vascularized connective tissue to injury, which is characterized by extracellular fluids known as exudates, and then leukocyte accumulation, for which the leukocyte we are talking about here will be defined dependent on the type of inflammation we are looking at. And then the accumulation is so that we can eliminate, remove, or clear the initial cause of injury and to initiate repair. We have to look at the causes of inflammation, because if we know the causes, then when we talk of the leukocyte accumulation and elimination, we can appreciate what is happening. If we don't know the cause of something, what would require or what would lead to the release of these leukocytes? It is actually the involvement of these causes or causative agents for which we would have our cells released, So we have physical agents, we will have chemical agents, we have biologic agents, immunologic disorders, genetic and metabolic disorders. And all these causative agents were made mention of even last 2 weeks and last 3 weeks. We see from this diagram that we have allergic reaction, we have chemical irritants, we have infections, trauma, injury, burns, lacerations, and frostbites. And these are causative agents, right? We can classify them into the physical, the chemical, and the other causes of inflammation. And we see that there is acute inflammation here, which suggests that the body would respond whenever there is an invasion or an attack on the body by these causative agents. And when the initial response fails, then we would expect that a more robust cell will be released. And in that, we are getting into chronic inflammation. If acute inflammation fails, chronic inflammation continues. But if chronic inflammation fails, then a disease develops. So we are seeing cardiovascular diseases, neurological disease. We have the autoimmune disease, rheumatoid arthritis, cancer, lupus, fibromyalgia. Then we have the chronic fatigue syndrome, right? Yeah. So all these are to help you appreciate all that we've been talking about, where we are looking at heat rashes, allergic reactions, immune diseases, sun damage. We have the infections, and you have photosensitivities. We have to look at the cardinal signs of inflammation. How would you know that what is happening here has something to do with inflammation, right? It has to do with the body responding to some form of injury. The signs which will be visible to the eyes will be heat, redness, will have swelling, you have pain, and obviously there will be loss of function. If you are to look at it in the light of Latin, then you are looking at calor, rubor, tumor, dolor, and functio lesser. Calor, tumor, rubor, tumor, dolor, and then we have functio lesser. And I tried to get pictures to represent what I was trying to say, or I meant by the cardinal signs of inflammation. So you have pain, you have heat, you have redness, you have swelling, and then you have loss of function. Obviously, when there is swelling, we know that there will be some challenges with the morphology. And from earlier lectures, you get to know that when there is a problem with morphology, function will be impaired or will be affected. Function will be affected. Okay. So we go on, and we have some picture here to bring perspective to the cardinal signs of inflammation. So you can clearly see that there is a tissue injury caused by physical or chemical agents or pathogenetic mechanisms. And you see that for us to have heat, there must be capillary widening. That means there will be vasodilation, for which you have hyperemia, a lot of blood cells, blood and blood cells rushing to the dilated area. And that's where you have the increased blood flow. So for that, you have heat. Then you have the increased permeability of the microvasculature. That's the endothelial cells. And that will lead to redness, because here you expect fluids like the exudates, and then you have red blood cells seeping through the endothelial cells into the basement membrane, right? And so you have fluid released into the tissue for the redness and the swelling. Then we have attraction of leukocytes, where you have the extravasation of leukocytes to sites of injury. So you have tenderness here. Then you have systemic response. That's where you have the fever and proliferation of leukocytes, and the outcome there, or the impact on the inflamed area, will be pain. In terms of nomenclature and types of inflammation, we are looking at organs that are affected, and the fact that we will have the surface itis added to it. We will have the surface itis added to it. So the disease associated with inflammation are usually denoted by adding the surface itis, like I said. So we have meninges of the brain inflamed, and you have meningitis. I know you have heard of peritonitis, lymphadenitis, and all the itis. The moment we have itis as the surface, it gives or brings to mind that we are looking at inflammation involved. In terms of the types of inflammation, we have two, and that is acute inflammation, and then we have chronic inflammation. Acute inflammation, and we have chronic inflammation. Let's look at some brief points here about acute and chronic inflammation. And we know that when it comes to chronic inflammation, it's a prolonged inflammation where healing has started. And when I look at this first bulletin, it brings to perspective the definition for chronic inflammation, where in chronic inflammation, we know three cardinal things are happening. There is the persistence of the causative agent or the injurious agent. We have active inflammation, and then we have attempts at healing. And so long as we have the causative agent or the infectious agent or the microbe persistent, it has the opportunity to continually release some form of toxins that will end up destroying the cells, healthy cells that are around. And so long as there is that destruction, so long as there is the persistence of the injurious agent and there is still destruction of healthy cells, inflammation would continue. And as it continues, there will be some parts which the cells there will try to undergo regeneration or repair. And that's why we are saying three things will be happening. There is the persistence of the injurious agent, we have the attempts at healing, and then we have active inflammation. The onset of the acute inflammation is rapid, whilst that of chronic inflammation is slow, because acute inflammation is more of the first response. So when there is damage, we expect inflammatory cells that are involved in acute inflammation to be released to the site. We expect the vessels to also respond accordingly, even before you have the cellular events. And then after that, that is when the acute inflammation fails, then you have the chronic inflammation following suit. When the acute inflammation fails, then you have the chronic inflammation following suit. And so chronic inflammation comes later, most of the time after acute inflammation. It comes later, or it comes after acute inflammation, and that causes kind of a delay, that causes prolongedness, and then it's also slow as well. Response in acute inflammation is more stereotypic. And let me even add this to this point where we are talking of chronic inflammation is slow. It's slow also because of the quantum of cells that are needed to be released to the site, because of the number of cells that will be lost. Okay. So response in acute inflammation is more stereotypic than chronic inflammation. We know that when it comes to acute inflammation, the steps are outlined, and whether the person is a black, a white, a Latino, a short, tall person, or whatever, so long as it's inflammation and it's acute, we know that those steps will be followed unless there is a defect somewhere. Other than that, we expect margination, we expect pavementing, transmigration, which is also known as diapedesis. Then we expect chemotaxis, and then we expect phagocytosis. But when it comes to chronic inflammation, we really don't see this conventional way outlined that way. No, you have a lot of things happening. Just like I said earlier, you have tissue damage still going on because of the persistence of the injurious agent. You have active inflammation ongoing, the body responding to it. And then on one breath, you also have the cells trying to regenerate or repair. Okay. So whilst acute is characterized by inflammatory exudates, chronic inflammation is characterized by granulation tissue formation. Let's look at some distinguishing factors between acute and then chronic inflammation. And it starts with the intensity and severity of the initiating insult. It starts with the intensity and severity of the initiating insult. And if you are to consider the intensity, if you have a paper cut or a scratch, the response of the body definitely will be acute, right? Acute inflammation will take place. But when you have a bull mastiff taking a chunk of the tissue of your thigh, or you have a car accident for which the impact of it is seen so much that you lost a lot of tissue, we expect that the response by the body will be chronic inflammation. So the intensity of it, the severity of the initiating insult would inform whether the body will respond by acute or it has to respond by chronic inflammation. Then we have the type of cellular infiltrates characterizing the lesion. So if I'm to give you a tissue that has been stained with hematoxylin and eosin, and I tell you that I expect acute inflammation to be taking place, what you have to look out for, because note that as at this point, you just have the tissue to observe. What you have to look out for will be the cells that will predominate in the histological picture. So for acute inflammation, you will find the polymorphonuclear leukocytes. The polymorphonuclear leukocytes, which is actually neutrophils. So you find neutrophils, then you will find monocytes. So in terms of acute inflammation, you have neutrophils, you have monocytes. But if I'm to show you another, I'm to give you another slide, and I tell you that concerning this slide, what is happening there is actually chronic inflammation. The cellular infiltrates that you find there, right, will be the macrophages, you find the plasma cells, you find the lymphocytes, you find the eosinophils. They are the cell types you find. And so by just seeing those cell types, the mononuclear phagocytic cells, it gives you an indication that what is happening here is none other than the chronic inflammation. The specific etiologic agent involved. So here we are looking at the causative agent involved. And it's usually a combination of all these factors or some of these factors, either a combination of the three, two of them, and we go on. If you are to consider inflammation and immune response, inflammation is considered as a form of innate immune response. And we know that inflammatory response is a reaction of cell damage regardless of its cause. And it's usually the first response. It's usually the first response, even though we have the adaptive, we have the acquired immune response, which follows later. But then if we are looking at the first response, we are looking at the innate immune response, then we are looking at inflammation or inflammatory reactions. What would be the outcome of inflammation? What would be the outcome of inflammation? What would be the outcome of inflammation? And here we know that if acute inflammation is successful, we expect that the causative agent or the noxious stimulus or the infectious agent right, or the injurious agent will be cleared or removed. Yeah, so we expect elimination of the noxious stimulus. And when that happens, there will be a decline of the reaction. The reaction will decline. And then there'll be repair of the damaged tissue. And then that will be it. For acute, that is, if we have a successful acute inflammation, we expect removal, elimination of the causative agent, the noxious stimulus. And when it is removed, because it was the causative agent that was causing the damage and releasing toxins, and we're seeing the effect. If it's removed, then the reactions will decline. And then the cells that were damaged will now have the opportunity to repair itself or regenerate. But then if you have the persistence of the noxious stimulus or the causative agent, what happens is that the journey will progress. It will be long. It will move from acute and then will end up as chronic inflammation. Chronicity will set in. And it is when chronicity also fails, then you have the development of a disease. When we look at inflammation, there are things to consider here. And that is the fact that we have blood vessels involved. We have the vascularized connective tissue and the blood vessel which has the blood flowing through it, laminar flow, which involves the cells of the blood, right, must respond. There must be migration, there must be activation of the leukocytes, and there will be some form of systemic reactions as well. I have this beautiful picture with a longitudinal cut through the connective tissue and then through the vessels, through the connective tissue, and then through the blood vessels. And clearly, is my voice clear? Can you hear me? Can somebody respond? Can you guys hear me?
Yes, sir.
Okay.
Yes, sir.
Yes, we can hear you, sir.
Yes, please.
Then I think that Emmanuel Chumesi, it's from your end. The problem is from your end. So you can check your thing out. Okay. So when there is a longitudinal cut through the connective tissue, even through the vascularized connective tissue, which is the blood vessel, these are the cells you find. You see that we have the connective tissue cells here. We have the mast cells, fibroblasts. We have the macrophages. They are in the connective tissue. We have the elastic fibers, collagen fibers, and we have the proteoglycans. If we are to go to the blood vessel, which is the vascularized connective tissue, in there we have blood cells, right? So we have the polymorphonuclear leukocytes, which is the neutrophil. We have the lymphocytes, we have platelets in there, we have monocytes, we have clotting factors here, where we are looking at complement components and even kininogens. We have eosinophils, and then we have basophils. But one thing is very important to me here with regards to the vascularized connective tissue, that is the blood vessel. The layers of the blood vessel, they are very much important in the lecture we are having, in that we have the innermost part of it, which will be one of them will be endothelium. If you are looking at more than one, then we are looking at endothelial cells inside here. Then we have basement membrane. Then from the basement membrane, we have the smooth muscle. So we have three layers here, endothelial cells, we have the basement membrane, and then we have the smooth muscle. Very important. And in there, we know we have a laminar flow, and with regards to the laminar flow, we have the cells in there for which we have the nuclear leukocytes, lymphocytes, platelets, we have the monocytes, even the clotting factors, eosinophils, we have the basophils as well. Okay. Please note that when it comes to the exudates, they will be the fluids that would seep through. You remember when I was talking about the cardinal signs of inflammation, I said that there will be the response by the microvasculature, which will lead to fluids seeping through the endothelial cells, even into the basement membrane, that would lead to the swelling. And I said that these fluids will be exudates, right? And so we want to know the importance of these exudates. We want to know the functions of these exudates. And the first one is the fact that it dilutes irritants in tissue, and then these exudates would carry with it fibrin clots so that if there is bleeding, the bleeding can stop. And even we know that these fibrin clots also assist in phagocytosis. Then we also know that these exudates will come with, or will carry with it opsonins and immunoglobulins, antibodies. And we know that these opsonins and immunoglobulins are important for coating the surfaces of our injurious agent or necrotic debris, or the causative agent, so that it will help with easier identification, recognition, and attachment. So the opsonins and the immunoglobulins are needed because they need to coat the surface of the cells, the necrotic cells, the microbe or the bacteria or the infectious agent, and then that coating will help for easier identification, recognition, and then attachment. So the exudates are important. It's not just the fact that there will be the seeping or the release of fluids from the blood vessel into the basement membrane, but then they are there actually to aid with the whole process of inflammation. There are times that the fluids you find, some of them might not be as I think I can see Augustine. You can ask your question.
My question is, please, I just wanted you to go over the exudates again, please.
Why?
The starting was okay, but it's like I was when you go the last part, I didn't get you all that, please.
So I said that the exudates would come with it opsonins and immunoglobulins, and these immunoglobulins and opsonins are to coat the surface actually of our necrotic debris or the causative agent, right? So that the phagocytic cells, when it's ready to phagocytose, will be able to identify, recognize, and then attach to those microbes or the infectious agents or the causative agent. That's it. Okay, so we go on. Let's look at I was saying earlier, let me start it from here so that you can get it. There are times that the fluids you find will not be exudates, but they will be transudase. When you look at our pregnant women, some of them will have swollen feet and puffy faces and arms and all that. Those fluids that were collected within the connective tissue are actually not exudates because there isn't any inflammation going on. They are actually transudase. And for you to know the differences between exudates and transudase, you have to look at the protein content and then the specific gravity. You have to know the protein content and then the specific gravity. For the exudates, it is actually rich in plasma protein. You note that it will be cloudy because it will be not only the plasma protein, but you have cellular debris, and then there is even the specific gravity, which is greater than 1.020. If we are to look at the transudase, they are quite clear because of the low protein in there, and then the specific gravity will be less than 1.012. Yeah, and if somebody would want to know how you'll be able to know if it is transudase or exudase, you just have to get the dipstick combined or competent from the lab people, because the ones that the midwives have will only have the protein and then glucose. But that of the lab scientists, they have about 9 or 10 parameters on their strip. And amongst those parameters, you have the protein and then you have specific gravity. And so when you dip it in there for the required period, You bring it out and you compare it with the color chart, and clearly you will see that if it is exudate that you collected, you will see that the exudate, because of the protein, because it's rich in plasma protein, you will see that it will either be from +1 to +3 or +4, and then you have the specific gravity being greater than 1.020. But if it was transudase that you collected, the protein will be either trace or negative. Yeah. And let me add that we know for exudase, we are looking at inflammatory reactions that would lead to the response of the endothelial cells, allowing fluids to seep into the connective tissue. But then when it comes to transudase, we are looking at an unbalanced relationship between the hydrostatic pressure and then the colloid osmotic pressure, which is also known as the oncotic pressure. So we know when we are talking about transudase, we are looking at unbalanced relationship between the hydrostatic pressure and then the colloid osmotic pressure, also known as the oncotic pressure. If you look at the normal blood vessel, where you have the arteriole, you have the capillaries, you have the venu, you have the oxygenated blood running through the arteriole. It's one, that's why. So the arteries, oxygenated blood. And then we get here, and then it's for the capillaries, you have the mixture of the oxygenated and then the deoxygenated blood. We come to the venous sector, and by this time we know that the oxygen has been spent, the nutrients has been spent, and that's why the color is blue there. So you know that the veins carry deoxygenated blood. We look at this point, and our interest is actually on the arrows, the green one and the red one. If our focus is on normal cell, right, normal flow, normal vessels, then we know that oxygenated blood will be pushed out of the arteries into the cells here, because they need the oxygen for oxidative phosphorylation and ATP synthesis. They need the nutrients for the cells. And so obviously, and so we have the colloid osmotic pressure, which is the returning pressure, lesser or smaller than the hydrostatic pressure. We come to the capillary level, and then there is a balance. You see the sizes are the same. But by the time we get to the venu, you see that the oncotic pressure or the colloid osmotic pressure is bigger, because by this time we know that we have spent the oxygen, right? So it must return into circulation. But when you look at acute inflammation, the whole vessel is inflamed. We have the arteriole, the capillaries, and the venous enlarged, dilated. Yeah. And then here you look at the hydrostatic pressure, and across board, the hydrostatic pressure is bigger, right? Fluids are being pushed out more, and then the return is very small, close to insignificant. So you have the colloid osmotic pressure here across, very small. And so this is telling you how the swelling comes about. So this is also to buttress or to help with the differences between exudase and transudase. And I spoke about all of them or mentioned them as I was talking about transudase and exudase. Now let's look at acute inflammation. Let's consider acute inflammation, which is one of the types of inflammation. For acute inflammation, we'll begin with the definition, and it's a rapid response to an injurious agent that serves to deliver mediators of host defense, where you have the leukocytes and plasma proteins, to the site of injury. The word there which catches my attention is rapid response. Rapid response. So we expect that within 6 to 24 hours, when there is an injury, within 6 at most, okay, even with the 6, it's because of the, when we are looking at cellular events, the release of the leukocytes. But immediately there is a damage, we expect immediate response from the vascular level, even to the cellular level. And so rapid response to an injurious agent that serves to deliver mediators of host defense. And you have the leukocytes and plasma proteins to the side. There are three major components to consider in terms of acute inflammation. The first one is the alteration in vascular caliber. First one will be alteration in vascular caliber. Second one will be structural changes in the microvasculature. And then you have the emigration of leukocytes, the movement of leukocytes from the microcirculation, that is from the blood vessel. So in terms of the first one, alteration in vascular caliber, where we are looking at the blood vessels responding to the activities of chemical mediators of inflammation. And for that matter, we are looking at the nitric oxides and histamine, the blood vessel responding to it. And it is as a result of the response that you will have the vasoconstriction and then the vasodilation. The vasoconstriction and then the vasodilation. Then we have the structural changes in the microvasculature. And these structural changes we are talking about borders with the endothelial cells. Remember, I told you that for the blood vessel, the vascularized connective tissue, we had three layers. The innermost part were the endothelial cells. One will be endothelium. Then you have the basement membrane. Then you have the smooth muscle. So in terms of the structural changes in the microvasculature, we are looking at response of the endothelial cells to these chemical mediators of inflammation, responding accordingly by ensuring contraction and retraction. And then we have emigration, where we are also looking at the cells leaving the circulation into the connective tissue and journeying from there to where the inciting agent is, so that it can phagocytose it or eliminate it for the reactions to decline, and then for regeneration or repair to follow suit. So let's pick the vascular events. And I started a bit of the vascular event, and this is where we expect the blood vessels to respond. And there are two ways by which it responds. The first one will be the vasoconstriction, followed by the vasodilation. The constriction happens in seconds. And so there are other books that don't even capture the vasoconstriction, but it's still important because we know that those constrictions occur as a result of neurogenic and then chemical stimuli. And then the vasodilation, where you have the arterioles and the capillary beds enlarging, dilating, increasing in size. And specifically the enlargement or the increasing in size will be the increase of the lumen, And this leads to blood and blood cells flowing a lot to those areas where there is dilation. And I told you earlier on that the dilation happened as a result of mediators of inflammation like histamine and nitric oxide. And so remember, when there is dilation and you have hyperemia, increased blood flow to the site, that's when the redness and even the heat, which were captured under the cardinal signs of inflammation, will be seen. I try to bring perspective to this by allowing you appreciate the lumen. So look at the lumen here for a normal vessel and look at the cells in there. But when we look at vasodilation, we see a lot of cells in there because of the hyperemia, increased blood flow. It will come with a lot of cells. We look at we compare it to the normal, and we see increase here. And even the lumen, we see an enlargement in there. If we are to consider vasoconstriction, the lumen becomes narrower or smaller than the normal one. And the cells in here are also lesser than the normal. Okay. And so remember that when there is vasodilation, we expect there to be increased permeability, which would aid with the blood flow to the site. And please also note that the cells, when there is dilation, the laminar flow, which was seen or which was actually the way of flow for which the cells were in the middle in terms of blood flow through the vessels, would not happen again, it will be rather stasis that will happen, or stasis that will happen. Because of the dilation, the flow will be slowed down, will slow down. You wouldn't have the flow being fast like it was before, because now the vessels have dilated. And when you have a lot of blood and then the flow is slow, the cells begin to now bump into each other and draw a bit closer to the endothelial cells. Very important. Okay. And note that even when there is the dilation, that's where we also find the vascular leakage because of the hydrostatic pressure, all the pressures that are supposed to happen, for which at the end of the day, the net flow into the connective tissue, even into the basement membrane, will be high. And that's where the edema comes in. So clearly we try to help appreciate the vascular leakage, and we can see the microvascular pressure, and we can see red blood cells trying to go through the endothelial cells, even to the basement membrane, and then it will lead to the local edema and even tissue damage if it persists. Now let's look at cellular events. Still on the journey, remember we said that we have the vascular events and then the cellular events. We made mention of 3 components, and one of them we were looking at the response of the blood vessel. We also looked at the response of the microvasculature, right? And then we looked at the migration of the cells from the vessel. And we are now looking at the cells, the phagocytic cells, and how they'll be able to get past the blood vessel, even into the connective tissue. So for the cellular events, we know we have these steps. Right? We have the margination, pavementing, and under the margination, pavementing, we expect rolling and then the release of adhesive molecules, even to the endothelium. Then we will see diapedesis or transmigration, where the cells will begin to go beyond, or across rather, the endothelium. And then we know of chemotaxis, because after it has gone across the endothelial cells, we expect that it would find its way to where the injurious agent is. And finding its way to where the injurious agent is comes with the chemotaxis. And then we have phagocytosis, which has to do with the engulfment and killing and degradation of the microbe or the causative agent. So let's pick the first one, which will be the margination, pavementing. So we all remember we talked about the dilation, we talked about the vasodilation. And so when there is dilation, the movement of the cells and the blood will now be stasis. So they will begin to bump into each other. And we'll see that because the flow is slow, now the cells will be coming a bit closer to the endothelium. When they begin to come closer to the endothelial cells, that's where you expect the expression of adhesive molecules. You have expression of adhesive molecules even on the surface of the endothelial cells. But before I even touch on that, look at what is happening here. These are beautiful micrographs helping us appreciate inflammation that is occurring, where here we are seeing vasodilation and vasoconstriction. Around this area, you have the vasoconstriction. And this area, you have vasodilation. So you can see where the vasoconstriction is. You have few cells there, but where you have the vasodilation, we can see hyperemia there. Okay. Then this also, you have the congestion, but this is a close range shot where we can see marginations as well. We can see the cells coming closer even to the endothelial cells here, coming closer. Then this is pavementing, where you clearly see the neutrophils attached to the endothelial cells. They are attached to the endothelium. You can see clearly they are attached to the endothelium here. Yeah, look at. So what you see around here, they are the neutrophils, the polymorphonuclear leukocytes. Still at close range for you to appreciate pigmenting. So look at it. So you have these parts are the endothelial cells or the endothelium, and then you can see the neutrophils binding firmly to the endothelial cells. Yeah.
Jesus.
So when it comes to, I'll use this picture here, or what we have here, to explain for you to appreciate what we are talking about in terms of margination, pigmenting, and transmigration. So please follow carefully. Follow carefully. So you have the neutrophils. Now it is the flow is in stasis. So you have the cells, because of dilation, you have the cells bumping into each other, and then they are marginating, coming close to the endothelial cells or the endothelium. And because it's coming close, by this time we expect some receptors or certain proteins on the surface of the neutrophil to be activated. So we have the Ciao-Lewis X modified glycoprotein, and then we have the integrins. But the integrins at this point will be at the low affinity state. So because of the modified glycoproteins, there must be complementary proteins. And please note that these complementary proteins were released, right, by cytokines like the tumor necrotic factor, TNF, and then you have the interleukin 1, IL-1. They were the ones that ensured the release of these P-selectins, the S-selectins here. And when the glycoproteins bind to the P-selectins and the E-selectins and the S-selectins, the neutrophils will begin to tumble, will begin to roll, move, because the affinity is not that strong to keep it firmly held or to cause it to adhere permanently. So we see that it will still continue to until the integrins have a high affinity state. So look at when it was at the low affinity state, it wasn't straight. There were some curves here and there, But at a high affinity state, you can clearly see that it is stretched out that way. And the complementary adhesive molecules that will be released will be the ICAM, the VCAM, and the PCAM. The ICAM here would bind complementary to the integrins, and they have a high affinity state. So when the integrins bind to the ICAM, the VCAM, and even the PCAM, you see that movement is no more possible. Rolling like it was is not possible. Now you firmly have pigmenting. And please note that the ICAM is intracellular adhesive molecule 1. Intracellular adhesive molecule 1. Then the VCAM, vascular cell adhesive molecule 1. Then the PCAM, you have the platelet cell adhesive molecule 1. Vascular cell adhesive molecule 1. You have the platelet cell adhesive molecule 1. And then you have the intracell adhesive molecule 1. Intracellular adhesive molecule 1. Okay, so it holds it firmly and prevents the movement. And then when that happens, we would see that the endothelial cells or the endothelium will undergo contraction and retraction from each other so that there will be space for the neutrophils or our leukocyte to go through. But when it crosses the boundary of the endothelial cells or the endothelium, it will find itself within the basement membrane. Remember, I told you that the blood vessel has 3 layers. We have the endothelium, we have the basement membrane, and then the smooth muscle. So even when it goes beyond or it crosses the endothelium, it will still find itself within the basement membrane. And that's where it will release enzymes known as collagenases. And these enzymes will pierce and break open the basement membrane and the smooth muscle so that our leukocyte or our neutrophil will go through, will escape from the microcirculation, escape from the blood vessel into the connective tissue here, into the connective tissue. into the connective tissue. So please, that is what is happening here. That's what is happening here. So let me go over that for those that missed some points here and there. Just touching on it once and then we progress. So I told you that for the vascular events, there will be constriction, dilation. The dilation will lead to hyperemia. We have a lot of blood that will be there with cells. And now there wouldn't be a laminar flow again, but then there will be stasis. And so the cells will begin to move at a slower pace, bumping into each other and coming down or closer to the endothelium. When they come closer, the leukocytes have receptors on their surface. And we have the glycoproteins and we have the integrins. The glycoproteins will come close, and then we have the cytokines like the tumor necrotic factor and then interleukin-1, helping with the expression of complementary proteins like the P-selectins, E-selectins, and S-selectins to the glycoprotein. But because the affinity between these complementary proteins, which is the glycoprotein and the P-selectin, E-selectins, are not stronger, it will begin to still roll. It can roll, move about like that until the integrin is activated. When the integrin is activated, there will be also the release of these complementary proteins like the ICAM, the VCAM, and the PCAM. And those ones, the affinity between the ICAM and then the integrins are stronger. So when it binds, when there is adhesion, right, there will be no more movement or rolling. So the rolling stops. And then I said that we would have the contraction and retraction of the endothelial cells as a result of release of chemokines and cytokines. And that will pave way, with the help of even the PCAM, for the neutrophil to go beyond the endothelial cells or the endothelium. And I told you that the layers of the blood vessel, they are actually three. You have the endothelium, you have the basement membrane, and then the smooth muscle. If it goes beyond the endothelium, you still have the basement membrane and you have the smooth muscle. So the neutrophils or the leukocytes will release enzymes called collagenases. And by these enzymes, it will break and pierce open the basement membrane and then the smooth muscle to allow it to move from the blood vessel into the connective tissue. I hope they got it fully. Okay. So we go on. So the mediators I was talking about, the histamine, the thrombin, interleukin-1, tumor necrotic factors, and then chemokines, right? And I made mention of the fact that you have endothelial cells, the E-selectins and all that. Yeah, so that's what happens. Then we have the VCAM, where you still have these same cytokines, ensuring their expressions on the surface and activation of even the integrins for firm binding, like I said. Yeah, for firm binding. For firm binding. So let's go on. And then I made mention of our enzyme, which is the collagenase, right? Yeah, I made mention of our enzyme, which is the collagenase. So we go on. Please note that for our cells, inflammatory cells, we expect within 6 to 24 hours neutrophils actually to be released. Neutrophils to be released, right? Neutrophils to be released. But then if within the 6 to 24 hours, the neutrophil fails to remove or eliminate the causative agent, then we expect the monocytes to also follow, right? The monocytes to also follow, very important. And so you have neutrophils, and then you have our monocytes also following. So these pictures are just to help bring perspective to all that I said. Okay. Yeah, so you can see the P-selectin, E-selectins, the PCAM and all that. And then I think somebody asked the question here. Yeah, so the person was talking about the, okay, somebody has even given the answer. Thank you. Okay, somebody is asking if clotting factors are the same as inflammation. No, please. Somebody even has also answered, so that's good. So now we come down to chemotaxis. And for chemotaxis, we are looking at, now we have a cell, right, a leukocyte in the connective tissue. How is it able to, how will it be able to know where the infectious agent is so that it will be able to phagocytose it? And clearly, we know that chemotaxis is defined as a locomotion oriented along a chemical gradient. And in terms of the movement, they are not the same. So there is different rate of speed with regards to even lymphocytes, monocytes, and granulocytes. But my focus is on what we call the chemoattractants, because they are very, very important. They are the ones that help give direction to and even lead the leukocytes to where the causative agent is. And so we have the endogenous chemoattractants, and then we have the exogenous chemoattractants. We have the endogenous chemoattractants, and we have the exogenous chemoattractants. For the exogenous ones, we are looking at the bacteria products, right? Products from the infectious agent. And then the endogenous chemoattractants, we are looking at the complement 5A, leukotriene B4, LTB4, interleukin 8. And the interesting thing is that when the chemotactic agent binds to receptors, specific receptors on the surface of the leukocyte, it sends signals down to the nucleus so that it instructs the cytoskeleton to polymerize, allowing smooth movement to where the inciting agent is. So as it binds to an endogenous chemoattractant, like there may be complement 5A, signals are sent, and then it leads to polymerization that allows the bending or the movement of the leukocyte. And then as it moves that way, it comes in contact with another chemoattractant like that, till it gets to where the causative agent is. And so I try to bring perspective to some of these chemotaxis, where you have the directional chemoattractant in fluid phase, you have the chemokinases, which is random, you have the chemoattractant and then you have the haptotaxis, where we are looking at chemoattractant molecules associated with surfaces, and you have the necrotaxis, where you have the necrotic cell plus the released substances. So this picture also is to help cause us appreciate the exogenous chemoattractants, the endogenous ones as well. Now let's look at phagocytosis. And for phagocytosis, it is the process of engulfment, internalization by specialized cells to particulate material, which include invading microorganisms, damaged cells, and then tissue debris. We have particulate material, which includes the invading microorganisms, and then you have damaged cells, and then tissue debris. For phagocytosis, we know that the phagocytic cells that helps with the elimination of the causative agent will be neutrophils, monocytes, and macrophages. So we know of the neutrophils, monocytes, and then the histiocytes. The histiocytes are the same as the macrophages. Okay. Now let's consider the steps in phagocytosis. We have recognition and attachment, we have engulfment, we have killing, and then degranulation. And for the recognition and attachment, we know that the microbe would have to be coated, and it will be coated with the antibodies or the opsonins we talked about earlier. Yeah. So you have the okay. So let me continue. So you have the opsonins coating the surfaces of the debris or the causative agent here. And then when that is done, we know the neutrophils or the leukocytes also have receptors on their surface for recognition and attachment. And these receptors, we call one of them mannose binding receptor, and then we have the scavenger receptor. Mannose binding receptors, we have the scavenger receptors. And so when by recognition and attachment, what happens is when it gets there, it holds on or binds to the microbe or the cellular debris or the necrotic cell that has opsonins on its surface. And when it's able to attach to it using the mannose receptors and the scavenger receptors, then it tries to internalize it by engulfing it. And when it succeeds in engulfing, we would see that there will be what we call a phagocytic vacuole that would actually be around the engulfed material. And then when it's engulfed that way, the phagocytic vacuole is called a phagosome. And you have a lysosome that will be released by the same leukocyte from internal, because right now, after the engulfment for which we have the phagocytic vacuole, we find the engulfed component or microbe inside of the leukocyte. So lysosome will be released and the lysosome will fuse with the phagocytic vacuole. Remember, I told you that the phagocytic vacuole is called phagosome. And then you have the lysosome binding to it. So the binding of the lysosome with the phagosome would have lead us with one thing called phagolysosome. So the fusion of the lysosome with the phagosome will be phagolysosome. And then we will have oxygen-dependent killing as a result of the generation of superoxide and hydrogen peroxide. And then there can also be the oxygen-independent killing, where we are looking at the lysozymes and others. And after that, after the killing, that will lead to the killing of the microbe. When the microbe is killed, there is the release of acid hydrolysis, which will end up leading to the degranulation or degradation of the killed microbe, so that there will be exocytosis of it. So remember, I said there will be recognition, there will be engulfment, right? And then there will be killing by oxygen-independent mechanisms. And after that, there will be the release of acid hydrolysis that will end up degrading or leading to degranulation of the killed microbe. Let me use this to bring perspective to what I've been talking about. This. So we can see recognition here. So we can see recognition here, right? You can see recognition up here and attachment. So the mannose binding receptor here. We can see this time the integrin is no more active because it has done its job. Yeah, it was able to bind to the ICAM, the VCAM, and has prevented the rolling and helped with its movement away from the blood vessel. And so clearly we see that there is engulfment happening here, where you have the phagocytic vacuole formed like this, and then you have the lysosome that was released from here to bind to it with the enzymes, and then we ended up with phagolysosome. And then there is killing, where you have the oxygen-dependent killing, oxygen-independent mechanisms of killing. And at the end of the day, there will be the release of acid hydrolysis, which would lead to the degradation or degranulation. Okay. Now let's look at the outcomes of acute inflammation. Let's look at the outcomes of acute inflammation. And we know that there can be one resolution. That is, if there is the elimination of the noxious stimulus or the causative agent, obviously reactions will decline, and then there will be opportunity for regeneration. And if that goes through successfully, then that means there is resolution, return to complete normality. Yeah, where there is the there is the capability of regeneration or repair, regeneration for that matter. And then the second one can actually be repair, where you have the replacement of damaged tissues by the fibrocartilaginous tissue, which would mature to form a scar. And then we talk about necrosis, where here we are looking at a type of cell death, one of the ways by which cell death occurs. We have abscess formations, and then we have the progression to chronic inflammation, and then we have spreading, especially when we are dealing with infectious agents. There can be spreading of the infectious agents to adjacent organs, and this results in cellulitis, lymphadenitis, and even bloodstream invasions. I have reading assignments for you, and that has to do with the types of acute inflammation: serous, fibrinous, hemorrhagic, suppurative, pseudomembranous. There are a lot. There are others there. So please, this is a reading assignment for you. Make sure you read, because you might not know where you will meet it. So please make sure you read. Now let's look at the disorders of acute inflammation. Let's look at the disorders of acute inflammation. Let's look at the disorders of acute inflammation. And for the disorders of acute inflammation, it borders around leukocyte defects. Whenever we are talking about disorders of acute inflammation, the weight or the challenge has always been with leukocyte function. When there is defects in leukocyte function, obviously there will be a disorder in acute inflammation. And that has always brought about recurrence of bacterial infection. Yeah. Because if you have the leukocyte not functioning appropriately, then you should be thinking that, well, then obviously chemotaxis will be affected, phagocytosis will be affected, killing and then degranulation will be affected. So you are looking at a lot of things that can actually delay the whole process and then would allow or give room for chronic inflammation. Okay. So we have neutropenia caused by leukemia and even drug-induced agranulocytosis. And in neutropenia, we are looking at the low count, right, of neutrophils. I always give this example. Imagine that there are armed robbers, about 100 of them invading a place somewhere, about 100 of them invading a place somewhere, and then you have policemen, just about 2-3 policemen released to the site. Obviously, you know that the 2-3 policemen cannot, they will be overwhelmed by the armed robbers. So if you have irritants, you have infectious agents, you have the body being invaded by microbes, and then we expect neutrophils to be released, and then we have very few neutrophils. Obviously, there will be still much more destruction, right? We have a lot of the cells destroyed. 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 Then we have disorders of leukocyte adhesion. We have disorders of leukocyte adhesion. So for the leukocyte adhesion, right, you have leukocyte adhesion deficiency type 1 and 2. Leukocyte adhesion deficiency type 1 and 2, very important. Then we have disorders of phagocytosis, and the causes will be, you have opsonin deficiency being one of them, hypogammaglobulinemia, where we have low count in terms of immunoglobulins or antibodies, and then even complement deficiencies. And research has shown that sickle cell disease has an effect on phagocytosis. Sickle cell disease is one of the causes of the disorders of phagocytosis. Then we have impaired engulfment. We have impaired engulfment. impaired engulfment, where you are looking at drugs like morphine and analog helping with that. And then we have the impaired granulation. We have some autosomal recessive disease like the Chediak-Higashi syndrome, which has one of its characteristics as impaired the granulation and even neutropenia. We have steroids and anti-malarials also contributing even to that. We have disorders of microbicidal mechanism, where you have the impaired hydrogen peroxide production. And we have all these ones, the chronic granulomatous disease, you have the glucose phosphate dehydrogenase deficiency, drug like hydrocortisones, you have the myeloperoxidase deficiencies, all of them being causes of the impaired production of hydrogen peroxide. And so another reading assignment, so I have all these ones also for you to further go and read: emphysema, hemorrhagic inflammation, catarrhal inflammation, pseudomembranous, membranous, gangrenous, serous, phlegmos. So all these ones are also there for your reading pleasure. So please take note of that. Yeah. Let me move on to one and see if we can just touch on it briefly. That is the chronic inflammation. If we can touch on it briefly, that would be fine. We are not able to finish two, we would finish later. There is a hand up. Okay, so Regina, you can, whilst I'm trying to share my slide, you can talk.
Yes, sir. So good evening. Please, about the enhancement, I couldn't capture it very well. Talking about the morphine.
About
I
the
would like
what?
to ask, why you give morphine?
About the what?
Morphine. You gave an example as morphine. So I wanted to ask.
I didn't give example. I said it contributes to something.
So, like, if somebody administers morphine, does it mean that the person, the inflammatory process, because of the morphine, then government will be altered or something will happen like that?
The morphine has an effect. What was it talking about? The morphine actually has an effect, right, on our on the ability of the cells to be able to undergo phagocytosis. Was it about phagocytosis? Let me check here for you. Yeah, so where is it? Yeah. Okay, yeah. We're talking about impairment of engulfment. Yes. So obviously the impact of the morphines will be seen even on the membranes of the leukocytes, right? And that's where it hampers or has an effect on the engulfment. Okay. So let's go on to what I really want to even touch on. If you've been taking pictures of it, it's good that you do take pictures, but listen, don't rely on these things, because if you fully, the reason I've not given you slides is to give you the opportunity to find and read materials that contain a lot of good information than this. If you only rely on this slide, and that's why I've not given to you, not that I don't want to give to you. I know some of you have been taking pictures thinking that they are smart and they are trying to get slides to read and all that. I'm rather trying to help you, because if you rely solely on this, you have a shock during the midterm and even the exam properly. You have shocks. So if you are taking it, thank God you are taking shots of it and whatever, but don't rely on it. Because I told you the informations around these topics I'm teaching, there are a lot, and then what I'm teaching here is just 1/4, because for 2 hours I can't bring all the informations here. So please take note of that. I don't want you to be surprised so much when it comes to midterms and exam. That's why I've been kind of prompting you on this thing. Okay, so let me do just some few touches with regards to the chronic inflammation. We see a picture here where you have chronic inflammation, you have the environmental factors, genetic factors, and out of it you have diseases. You have diseases. Yes. And the key thing here is to take yourself back to that diagram where you had the causes, you had acute inflammation responding, and then you had rather the chronic inflammation not as acute. That's what this picture is telling you. And if in that regard, when it fails, right? When it fails, we expect that clearly you will have a disease. You will have a disease. Clinton is asking for outline. Clinton, the very first day, I don't know if you are a late comer or something, but the very first day I came around, the outlines were made known to the class. I actually projected it and scrolled through. Okay. So in terms of the learning objectives, we have to define and explain chronic inflammation, list the cells involved in acute inflammation and describe how they function as chronic inflammatory cells, state the factors that predispose to chronic inflammation and explain how they result in development of chronic inflammation, and then be able to describe the types of chronic inflammation and how they function, and then states the primary cause or states the cause of primary chronic inflammation, describe chronic granulomatous inflammation and its pathognomic lesion, which is the granuloma. We look at the definition for chronic inflammation, and like I said earlier, three things are happening. There is tissue destruction, there is acute inflammation, and there are attempts at healing. And there are attempts at healing, right? There are attempts at healing. And then we note that from the definition, we had macrophages, lymphocytes, plasma cells. We included the predominant or the cell types of chronic inflammation in the definition. And they are the macrophages, the lymphocytes, and even the plasma cells. And remember that if we are looking at healing that occurs whilst chronic inflammation is ongoing, the healing will be by repair. By repair. And most of the time, even after chronic inflammation, when the body wants to replace the cells that were lost, they replace by granulation tissue. Replaced by granulation tissue, which ends up becoming scar, and that will be repaired. When we look at the chronic inflammatory cells, the most important of all the cells there will be the macrophage, which is the histiocytes. And let me be quick to say that the cells of the blood, you don't have macrophage as part of it. You don't have macrophage as part of it. Actually, we have monocytes, right? And so when neutrophils are released within 6 to 24 hours and it fails to eliminate, you have monocytes also moving to the site. When monocytes gets there, it is supposed to eliminate the cause of injury, but if it fails, then there will be the release of chemokines and cytokines and other chemical mediators that would transform the monocytes to become a large phagocytic cell known as the macrophage. And when the monocytes are transformed to become macrophages, then we will see that they will also go on to activate the macrophage. And when the macrophage is activated, it releases some proteins from itself. And those proteins are responsible for fibrosis and then angiogenesis. Fibrosis and then angiogenesis. And then note that even though we are saying the most important cell type is actually the macrophage or the histiocytes, there are other cells like the lymphocytes, the plasma cells, and eosinophils. And that is not all. The in terms of the histological picture, there are certain diseases or certain inflammations that, in as much as macrophage is very important and macrophage is considered as the main cell when it comes to chronic inflammation, in terms of diagnosis, there are certain inflammations that you will not find macrophage as the diagnostic cell. The diagnostic cell you find might be the lymphocytes or even the plasma cells. And I have examples like the chronic inflammatory lesions, where the predominant diagnostic cell type will be the lymphocytes. And when you are looking at the chronic endometritis, the predominant cell type will be the plasma cell, which is also the diagnostic cell. So we have cells of chronic inflammation. We have cells of chronic inflammation. You have cells of chronic inflammation where you have the plasma. We said earlier, they are all mononuclear phagocytic cells. In terms of predisposing factors, we know that chronic inflammations, most of them follow up on acute inflammation. And I told you earlier, when acute inflammation fails, then you will have chronic inflammation following up. But there are instances that from onset, from beginning of the injury, the response by the body will be chronic. Chronic inflammation would take place. And if you are to look at the chronic inflammation that started from acute, you know that then there must be the persistence of the causative agent. And in that regard, remember that there will be exudation in acute inflammation. There will be neutrophil release, monocytes, and the monocytes will be transformed to become macrophages. So it's not a wonder when in chronic inflammation, based on the persistence of the injurious agent, you find exudase, you find polymorphs. Immediately you find that with macrophages, it tells you that this chronic inflammation started as acute. Okay. That's not all. So factors that predisposing to development of chronic from acute inflammation, you have the persistence of the injurious agent, and then some interference with the normal process of healing. So if you have the persistence of the injurious agent, you have the interference of normal healing, definitely you are looking at chronic inflammation here. And then we have the presence of necrotic and exogenous materials that are able to resist liquefaction, like the wood, the talc, the sutures, and others. If you have some metal hiding itself in your skin or somewhere, definitely your neutrophils or your leukocytes or even your macrophages cannot phagocytose that. And immediately you have something like that, you know that even when it started as acute, it will end up as chronic inflammation because there is no macrophage, or there is no macrophage or even neutrophil that actually can be able to phagocytose a wound. Very important. Okay, so organisms may persist in crevices too small for access to polymorphs or biopolymorphs. And this one, we are talking about the size, right? The size of the organism, the microbe, playing to its advantage. Because if it is too small and then the receptors of our polymorphs are not able to get it, that means that the causative agent or the microbe will persist and release toxins and continue to destroy healthy cells. In the situation where we are looking at where we are looking at defective leukocyte function, you know that if your leukocytes are defective, even when it starts as acute, it will end up as chronic. In situations of impairment of any of these functions, you know you have prolonged injury of tissue loss, and then you have accumulations of large numbers of functionally incompetent neutrophil. That is not all. You have congenital deficiencies of neutrophil-specific granules. The granules are morphologically abnormal, and that means when it comes to the killing, it will not be possible. The granulation will not be possible. We look at disorders of neutrophil adherence, lazy leukocyte syndrome. And this one, remember I told you that at most within 6 to 24 hours, the neutrophils must be released. There are other people that the neutrophils will be released when you have like about, they will be like maybe 72 hours. In 3 days, that's when you have the neutrophils now being released. And when you have delayed like that, definitely you should expect a lot of cells to be destroyed. And the possibility of ending as chronic inflammation is very high. When you have defects in phagocytosis by neutrophil polymorphs, like you have deficiency in complement 3A, when we are looking at a situation where immunoglobulins are not being produced, deficiencies of immunoglobulins, X-linked Bruton's A gamma globinemia, when you have absence of opsonins also, and when you have defects in phagolysosome function. I told you of the Chediak-Higashi syndrome, where we have the autosomal recessive disease. Told you of the neutropenia, defective degranulation, and delayed microbial killing and all that. So we can also look at some examples of chronic inflammation. And the first one will be chronic suppurative inflammation. Chronic suppurative inflammation, where here it will start as acute suppurative inflammation, and it's characterized by pus and abscess cavity. And so you see that you have pyogenic membrane that is formed to wall off the abscess from adjacent viable tissue. And by that, you find out that the abscess will become rigid. And when it becomes rigid in that way, we have to do incision and drainage, the surgical intervention to deal with it. But then naturally, it can also escape to the surface of the skin or wherever it is, and then it can collapse or we can break it. Okay. And remember that when that happens, we expect that the healing process will be by repair, and there will be scarring. It will mature as a scar. You have the chronic suppurative inflammation here. Yeah, chronic suppurative inflammation here in pictures, micrographs, like that. Then we have the non-specific chronic inflammation. Non-specific chronic inflammation, and this is from some causative agents, specifically the foreign body ones that don't induce exuberant polymorphs. Yeah. So most examples of chronic inflammation are not associated with formations of pus in chronic suppurative inflammation. So these ones are not. This one, non-specific, no pus formation here. And interestingly, even when you have fibrin exudates and polymorph accumulation, there wouldn't be liquefaction. And so here you find macrophages, you find lymphocytes, and even plasma cells. And it continues like that for us to have the suppurative and non-suppurative inflammation micrographs. So these are photomicrographs to help you appreciate the suppurative and then the non-suppurative. Then we have the primary chronic inflammation. And this inflammation, it starts from onset as chronicity or chronic inflammation. That means that the cells you find will be the mononuclear phagocytic cells, the histiocytes. There will be no polymorphs, or even if there are polymorphs, very, very few. That means that there will be, it's from beginning, and then if even there will be an acute phase, the acute phase is insignificant. The acute phase is insignificant. The acute phase is insignificant. So this is a micrograph of primary chronic inflammation. And interestingly, you can see multinucleated giant cells here. All the cells here are monocytes. They are macrophages. They are mononuclear. That's what I want to say. They are mononuclear phagocytic cells. And clearly you can see even epithelioid macrophages in there. And epithelioid macrophages are actually activated macrophages. So let's look at the types of primary chronic inflammation. There are two types. The first one, where you have the immune system itself responsible for most of the injury. And then the second one, where you have the mononuclear phagocytes dominating the histological picture. And the cause is not different from what we talked about. When the agent is able to resist phagocytosis, the agent able to resist digestion, the agent is a body constituent, and then when you are dealing with autoimmune diseases. When you also are dealing with chronic, you have the primary granulomatous disease or specific disease of unknown cause, specific disease of unknown cause. So you have the sarcoidosis as examples of the primary granulomatous disease and Crohn's disease. You have the ulcerative colitis as part of the disease of unknown cause. And if you look at the pulmonary sarcoidosis, you have these symptoms right here: chest pains, you have the wheezing sound, you have the dry cough, and then shortness of breath, which worsens with activity. When you have to look at the Crohn's disease, here we are looking at the large intestines having patchy inflammations. Look at the normal one here, the colon. Look at the colon here, and even the ileum. And look at within the colon, the lumen of the colon. No problem here. But when you look at the Crohn's disease, where you have the ileum and then the colon, affected, you have thickening of the walls, you have cobblestones in there, and then you have fistula. And so when we also look at remember we are still under this. When we also look at the ulcerative colitis, we have the proctitis, proctosigmoiditis, distal colitis, extensive colitis, and then you have the pancolitis. And you can see the inflammation where it stands and it extends. And then by the time you get to pancolitis, you have all your colon inflamed. If you are to look at the ulcerative colitis as in versus the Crohn's disease, the difference here is that in terms of ulcerative colitis, we are looking at the large intestines, entire large intestines. We look at the Crohn's, and then it can start from the mouth down to the anus. Inflammation can start from the mouth down to the anus. Then we have the special form of chronic inflammation, where for the special forms of chronic inflammation, we have the chronic granulomatous inflammation. And this is interesting because this is a specific type of chronic inflammation where we have a new type, not a new type, but a modified type of macrophage known as the epithelioid macrophage. And these epithelioid macrophages, they are able to fuse with each other. When they fuse with each other, they end up forming what we call giant cells, multinucleated giant cells. Because every macrophage has a nucleus, when you find these epithelioid macrophages joining, they join or they fuse to become one, and then you have a lot of the nucleus in the giant cell. So we have three types of giant cells. We have the foreign body giant cells, Langerhans giant cells. The granuloma is the focal area, the area where the granulomatous inflammation is happening. And there you will find epithelioid macrophage, you will find lymphocytes, and you will find plasma cells. So there is a picture of the granuloma where you have the lymphocytes, you have the epithelioid macrophages or histiocytes, and look at the multinucleated giant cells here. Inside, you have 1, 2, 3, 4, 5, and 6. That means that you have 6 epithelioid histiocytes that have fused to give us this multinucleated giant cells, because you have a lot of the nucleus in here, the 6 of them. Okay. So there are 2 types of granulomas. We have the foreign body granuloma, then we have the immune granuloma. We have the foreign body granuloma, and then we have immune granuloma. And one key thing is this: when you look at the foreign body granuloma, it's actually incited by a foreign body, a suture, a tack, organic dust, metal, and the kind of giant cell that will be formed will be foreign body giant cell. When we look at immune granuloma, for which we know that the immune cells are implicated, the kind of giant cell that will be formed will be the Langerhans giant cell. So this is a foreign body granuloma. Look at the giant cell here. Yeah, inside here. And then you have the immune granuloma. Same way you see the giant cells here. There also, and there. Then we have a summary of all that we've been talking about in terms of the chronic inflammation. So it starts with the fact that in chronic inflammation, there is tissue destruction induced by the inflammatory cells, and you have active inflammation that occur at the same time as attempts at healing, which usually ends in healing by repair. The predominant cell type is the macrophage, which may be accompanied by lymphocytes, and then you have the acute inflammation being followed, right, by chronic. And then there are some also for which the chronic inflammation will start from onset. Remember the second bulletin, we are talking simply about the cell types of chronic inflammation. Made mention of macrophage, made mention of lymphocytes, talked about plasma cells, and even eosinophils. And we know that for us to have acute inflammation crossing over to chronic inflammation, then there should be the persistence of the injurious agent, or there should be leukocyte dysfunction. And under that, we looked at some types of chronic inflammation where we got to know of the chronic suppurative, which is characterized by abscess and then pus formation. But the chronic non-specific, you don't have any pus formation there, clearly. And we know that it's induced by some agents that don't sequester or lead to exuberant polymorphs. And then we know that it also arises in the settings of autoimmune diseases. That is when you are talking about the primary chronic inflammation, which we know that can start from onset, which we know starts from de novo. Then we have the chronic granulomatous inflammation, which is a special type of chronic inflammation. And here we know of the fact that you have predominant cell type where you have the macrophage, but these ones, they are modified and they are called the epithelioid macrophages or the epithelioid cells. So that is it for us for today. Please make sure you are studying, and God willing, we'll do next week. We'll go on to another topic, and the next 2 weeks we'll write our midterm. We'll write our midterm. We'll write our midterm. So see you next week, exactly the time, and then we'll go further and deeper into other aspects as well. Okay, so have a wonderful evening, and then catch you when I catch you. Bye-bye.
I bet you can post sister. Pana compare FLS lesson na wasa onye ton fa book my why na I know that we now was we me abet me we nyina bet me go trim
na when you cram was we cram pathology